All right, TBI. Welcome to TBI. Well, acquired brain injury. So for years, for me, this was just, we used to call them TBIs, brain injuries, and somewhere along the way, they decided to lump everything together, acquired brain injuries. So any kind of damage to the brain that occurs due to, after someone is born, it's not congenital and not degenerative. What are some examples of something degenerative? Alzheimer's. Yeah, multiple sclerosis, good, that's good. Yeah, we're going to talk about all that stuff too, but things that are more progressive in nature, deterioration caused by various things, but it's not categorized as a traumatic, or as an acquired brain injury. It does include traumatic brain injuries caused by trauma. It does include brain tumors, and it does include strokes, although we talked about strokes already separately. So there's some facts for you. Anybody want to guess why men are more at risk for developing TBIs than women?
They're reckless.
Whoa! That was harsh. Reckless. Ouch.
Out of control.
I thought so out of control. I thought someone was going to say stupid.
They cheat so much it stress them out.
No, come on, man. I mean, it's you and me, buddy. It's you and me. I don't know. I was just going to say I have no idea why. Men tend to be. I thought this was interesting. Rural areas, we see more TBIs in rural areas than in. They're jumping, playing chicken with tractors. So, no, seriously, for real. I mean, why do you think there are more brain injuries going on in rural areas? Maybe the stuff they use out there, like tractors and four-wheelers and such. What?
A lot more physical work and then hunting.
Razor accidents are huge in my area.
Yeah. So some of the stuff that's going on there, maybe it's occupation related.
That's what I'm thinking.
Right? The occupations that go on in rural areas may lend themselves more to injuries than people in cities aren't doing stuff.
But even with motor vehicle accidents, you see a lot more risky
Not
driving because you don't have as much patrolling
and they're driving at higher speeds. You're not driving at high speeds in the city, right? In metro areas. Unless you're in Dallas, of course.
You have more people riding
They're all
public
flying.
transportation.
Found that interesting, anyway.
Yeah.
So there's some stats about TBIs. Big one, and I've mentioned this probably before, but the most common cause of acquired brain injuries in children under 5 and the elderly are falls, right? So that's why we're so fall risk minded when we work with older folks. I am all about fall risk and minimizing fall risk because it's the #1 cause of fractures as well in the elderly. So when my old people fall, nothing good happens, okay? Fractured humerus, whatever, hips, brain injuries, all kinds of stuff. So we'll talk more about that probably down the road, but motor vehicle accidents are the most common cause in adolescents and adults, and of course, intoxication is often present with this. So we're going to talk about 3 types of TBI, traumatic brain injury. There's the focal, there's the diffuse, and there's the intrusion by some penetrating object. So with the focal, it's on that one spot for the most part. Diffuse, we're going to see more damage out within the brain in other areas. And that's more common with motor vehicle accidents. There's more going on, there's more brain damage, covers a larger area.
Same with like bombs and now with sound. They've done a lot of studies with like shooting cannons and stuff for people who are even training in the military.
Really?
And
like
they now
brain
have,
injury
They
from...
now have brain injuries.
So is there something concussive then about...
The loud sound of shooting off cannons. And
That could
different
explain a
things.
lot. In my Army days, all the guns and stuff. So.
It depends on how big and how close you are, but yes.
But yeah, well, I know the hearing obvious was obvious, but the concussive, I haven't really thought much about that.
There was a New York Times article a few weeks ago.
So,
But yeah, sorry.
that's okay. We'll talk about these here, though. So diffuse axonal injuries. So does this take you back? A little walk down memory lane here for you, right? it's a good time to review your neuro. It's still pretty fresh in your mind, I'm sure. But you see that axons, remember your brain is just a bunch of nerves. And nerve damage at the cellular level, we talk about how you can have shearing of the axons, you can have post-trauma, you just have these damaged neurons, these damaged nerve cells. And we also talk about coup. It's not very good on here, but it shows up better on your screen probably. The coup and counter coup of the brain injury. The initial, let's say that the trauma happens here. That would be considered the coup. Your brain slamming against the object, the skull, that initial part. But then the response, the counter coup, might be on the opposite side of the brain. That counter coup from the trauma of banging against your skull in the back. So you can see how a traumatic brain injury might involve multiple areas and be very diffuse throughout the brain. So the primary injury, so there's primary brain injury, and there's also secondary brain injury. You see the primary brain injury very much like a stroke in that no two brain injuries are alike. And how bad a stroke is, I said depends on where it is, where it occurs, and how much brain damage there is, how much brain tissue is affected. Same thing with traumatic brain injuries or acquired brain injuries. Where does the trauma or the incident occur, and how bad is it? How much brain tissue is affected? And you can see some of the things where it happens. You guys have had neuro, so you know that if it happens in this area, the motor cortex or whatever, you're going to see involvement in voluntary motor function, and et cetera, et cetera. Where it occurs affects how that person functions, how it impacts function. The secondary things that happen, you might see intracranial pressure that causes effects. You might see ischemia. What's ischemia? Lack of blood supply to a particular area. You might see some intracranial bleeding, some hemorrhaging going on, secondary to this injury, swelling. You might see seizures. Hydrocephalus is a condition of fluid on the brain, buildup of cerebrospinal fluid. You might see some cardiovascular complications, some respiratory complications, especially if the autonomic nervous system is affected. If the brain injury includes like brainstem functioning and cerebellar functioning, you might see autonomic issues as well. Come back to me. Man, I was on a roll.
Unplug your computer or just.
Yes. Has anyone had any interaction with somebody who's had a brain injury?
Yeah.
In your practice?
One of my best friends.
One of your best friends?
He had a wall fall on him. A wall machine.
You had a what?
A wall. It was like a poorly supported wall, and it fell onto a machine that fell
Oh my gosh.
onto him.
How old was he?
Early 20s.
Late 20s.
He was in the Army. And working with the dogs, like he was one of the trainers for the dogs, and he had went down to get some stuff for the animals.
So it was work related or service related? Anybody else knows
I've
anything?
had a lot, but I also have a certification from when I was teaching that was in TBI, and it was like a 40-hour certification that I took. And they brought in different TBI patients from the Tulsa area. It was very interesting to me because every one of them said when they left the ER or whatever, like one kid, he was like on the soccer field and they were hanging onto the Jeep, boy, of course, and the Jeep went forward and he just fell and hit his head, but he had a moderate TBI. And when they like discharged him from the ER with a pamphlet, here's what TBI is, you know what I mean? They don't really get a lot of education on what's going on. And one of the things was his olfactory system was compromised, and they didn't know it until they drank spoiled milk and got really, really sick.
Oh, wow.
So, I mean, I found that interesting that the education side from the
Oh,
hospital
gosh.
is really
And
lacking.
you've seen that with your practice anyways.
Yeah.
Clearly, you've seen that over and over again. Did you have that?
Yeah, I see it at work, but I have a friend at church who was in a car accident, and so she presents with like bilateral lower extremity weakness, wears 2 AFOs, and she drives, but she got a divorce after it because she was not the same person. She's remarried, has a husband now.
So she was different after that. Wasn't there a movie? Wasn't there a movie about
50 First Dates.
the vow?
Oh.
Wasn't it the vow where she had a head injury, right?
Or
No, not Dear John.
No, the vow.
Not Dear John. I saw that too.
I was like,
The vow.
50.
Isn't one of the sites that you guys often hear Brookhaven?
Yeah, Brookhaven was one of our
So I
football
worked there
sites.
for 5 years, and you see a lot of people who, not only do they have these brain injuries, but they have at-risk behaviors. So
Ah,
it's-
yes.
their behavior is very like, they have these impulsive.
And personality changes, like
Yes.
she was talking about the frontal lobe, especially if it's affected, right, can really be, that person can be a very different person.
My cousin fell off the back of a tractor, no, I'm just kidding. Off of the back of a truck, and he like almost died, and he ended up like now like one side of his face like droops more than the other. Like when he smiles, like only one side of his like face comes up. It's like a crooked kind of smile now. But yeah, that would happen whenever he was younger. He's probably like in his like mid-40s now.
Man.
Yeah.
So when you're practicing and you're seeing patients, you get a brain injury, you don't think, oh my gosh, yeah, brain injury, this is what the person's gonna be demonstrating or manifesting. Because they're all different, right? So where's the brain injury? What areas of the brain are affected, and how badly are they affected? And then as you get to know that person, then you can, you start working. That's what assessments are for, though. But don't prejudge, I guess is my point, by the diagnosis. The diagnosis doesn't tell you, just because it's a good start, it's just a good place to start. Now we got to figure out what's going on, right? Okay, so anyway, these are the secondary complications that might be impacted depending on the brain injury. And there are some complications that those things cause, and I mentioned issues with the autonomic nervous system, and we would call that dysautonomia, that impaired functioning of the autonomic system. So you might see this. And people with a Glasgow Coma Scale, which we'll talk about here, a lower Glasgow Coma Scale often will have more involvement of the autonomic nervous system. And those people are the people you may be encountering in ICU. If you work in hospital settings and you have an ICU and you get that patient in there, and they might be on events and they may have other things going on with their autonomic nervous system. DVTs, you might see they've been immobilized for a while. They might have developed a deep vein thrombosis, and so they're more high risk for developing a pulmonary embolism. And coma. You see people with brain injuries in comas, and I've worked with people in comas, and that's an interesting person to work with, somebody who's in a coma.
It's not like it is on TV.
What?
Everything you read are like, it's not like it is on TV where you're like, oh, you're in a coma, oh, you're okay, 10 years later you get up and then you have an adventure.
Yeah, a lot of our coma folks don't come out, and some of them do. And so you never know when someone's in a coma, you never know what they hear, what they don't. And so I always try to say, let's not presume they can't hear us and understand what's going on. Maybe we should presume that they do, and we can talk to them like they do, and we can work with them like they do. That way, in case they do, we're meeting some needs there. So, some medical complications also that you'll see with brain injuries. You'll see decerebrate rigidity, and you will see decorticate rigidity. So, when you think of decorticate, I'll pick the bottom one first. When I think of decorticate rigidity, I think of the cerebral cortex. okay? So it's gonna be a flexion posture, a flexor posture, which is caused by damage to the cortical area. And the brain stem is not as affected, so it's more of the cerebral cortex, not affecting the brain stem, so you don't have that lower brain functioning stuff going on. And so decorticate rigidity, you're gonna see a flexor posture, so the elbows are flexed, that's where that comes from. So the flexor, the biceps, some of those elbow flexors are really hypertonic, and they're causing this flexion of the elbow, whereas the antagonists, the extensors, the triceps, the extensor muscles there, are lower tone, they're hypotonic, and they're not antagonizing like they normally would. So you got two things going on causing this flexor posture of the elbows. And there's still though an extension of there's also an adduction at the shoulders, flexion at the elbows. You're gonna see this extension of the knee and plantar flexion of the ankle, right? That's gonna be a decorticate. That's a great test question on your midterm. Decorticate rigidity. I'm not saying it will be on there, I'm just saying. Whereas decerebrate rigidity is going to be more brainstem damage, and you're going to see more of an extensor posture here at the elbow. So you still have adduction at the shoulder. You're going to have this extension posture going on because these muscles are hypertonic. It's extensors, okay? But you're going to see flexion. I didn't mention flexion of the wrists here, but you're still going to see that. But notice you're going to see more of a pronation of the forearm and a flexion of the wrists. You still have the extension in the knee, plantar flexion at the ankle. So the big difference is the extensor tone at the elbows and the pronations. Well, pronations are a bigger deal. There.
Dr.
So,
Leonard,
yes.
do you try and break up those contractures when you're seeing them?
Yeah, so what I want to do is I want to gently I want to start affecting tone, right? I want to start normalizing, I call it normalizing tone. So I want to start stretching some gently. And so with tone, when we handle tone, and I have an imaginary upper extremity in my hands right now, okay? So I'll pick an arm, I'll pick a real arm. So if I have tone here, she's really pulling in, adducting at the shoulder, and she's flexing at the elbow. I'm gently going to try to slowly, gently pull in the opposite direction. I'm going to stretch a little bit. But I have found that slow, sustained stretch helps to relax tone, right? I might even apply some deep pressure in certain places, wherever those muscles are. Prolonged helps to inhibits tone, relaxes the nervous system. And so I can start stretching, and I might even come here, and if she's really pulling against me, I want to just slowly work out, stretch in the other direction. These biceps are so tight. So I want to pull away into extension and slowly stretch. So I'm going to just slowly and take my time and stretch it out for quite several minutes. Just really relax. Try to see, and you can feel things start to relax a little bit. And over time, thank you for your arm. Over time, the idea is, and it works with some people really well, the tone begins to decrease and you start normalizing that. Some folks will respond pretty well and some folks just won't. So you give it a shot. You know. Yes, sir.
Is there like a time frame that you look for when fractures like set in place in knee surgery, or is it like very for like individual?
Yeah, you don't see a lot of the. I haven't seen a lot of the surgery in my life. They got to get really. They've been like that for a long time, and I've had people. I've had people, and it's more with strokes in nursing home settings where they'll just go with this spasticity for a long time, and nobody does anything about it, and then I get a referral. Hey, can you work on contractures? And I'm like, now you call me in, But I've had good success over time, but I got to take my time and work it out day after day after day, and use orthoses, use orthotics as well to help. Stretching somebody for 30 minutes or 45 minutes and then not seeing them again for 24 hours doesn't always do a whole lot of good. Depends on the person. Sometimes it does, but so I need something to keep that. That's what splints are for. That's what orthotics are for. to try to keep them from drawing back in, and I progressively can work them out over time. But it's amazing how successful we can be, even with people who are really locked up. If we take our time and we use these inhibitory techniques like pressure or vibration and just slow stretch, we can progressively work them out into better range of motion. So, yes.
Does using modalities help with that?
I like using with spasticity, I like using ultrasound, and I have used some E-stim in the past, and I feel like the heat is good. I like hot packs too, although they're not as effective. Maybe the thermal ultrasound, I like that a lot. A modality as a preparatory, it's preparatory so that I can stretch. But I also find that just deep pressure of soft tissue, relax. That's what massage is all about. Deep pressure, slow, deep pressure, relaxes, and then I can stretch that tissue out a little bit. That's pretty darn effective. Yeah. Okay, so you know this. You'll see people like with this kind of rigidity, or these kind, in hospital settings especially, or maybe even a nursing home setting. You might see some of these medical complications as well, especially with motor deficits. They may have abnormal reflexes, quadriparesis, hemiplegia. Quadriparesis, what's quadriparesis? All fours are partially paralyzed, weakness in all four extremities. Hemiplegia is half of your body is paralyzed. Monoplegia, what's that? One extremity. Spasticity, heterotopic ossification. You might see some bony calcification, some bony tissue building up in weird places if they've been sitting too long, immobilized too long. You may see tremors. That's usually an incoordination problem, or it could be just a motoric brain problem. And ataxia. What's ataxia? Lack of coordination or impaired coordination with motor movements, right? Especially walking. I think of it with lower extremities with walking. Okay. You see cognitive issues with the brain. It makes sense, right? Especially depending on where the damage happens. Retrograde amnesia. What is retrograde amnesia?
Is it previous to your disease or after?
Well, you tell me. I'm
trying to
asking you.
remember. I think it's previous.
So what
can't
about it?
remember
You
what
do remember everything previous, or you don't remember everything previous?
Don't.
So you do not remember what happened before the accident, right? And anterograde amnesia is
An ability to build long-term afterwards.
an ability to do long-term afterwards. Yeah. So, am I getting this right? Retrograde amnesia? I forget.
I think so. I think in
Yeah.
the book, the definitions were just anterograde was before retrograde. That's why I was thinking.
Oh yeah.
But I think you're getting it right.
Yeah, that's right. That's right. So retrograde amnesia, I don't remember what happened before. Anterograde, I don't remember anything that happened afterwards, after the accident. And I've had patients with both of these, not both at the same time, but I've had patients that have had these. And somebody asked them what happened to them. They have anterograde amnesia. A lot of times they can't tell you what happened to them. Maybe cognitive functioning will be impaired depending on where the brain injury occurs. ADL impairments are the big thing that we see, of course, and motor function, sensory function, cognitive issues, whatever, poor attention, executive functioning. When I think of these kind of stuff, I'm thinking of memory. I'm thinking sequencing, multiple step activities. I have had a lot of patients that they can't do a 2-step task, a 3-step task. So I really will focus on breaking things down into 1-step, 2-step, 3-step. That's a great way to grade the ADLs, the tasks, and it's a great way to write goals as well. They can perform a 1-step task with standby assistance, but 2-step, they need a lot more, whatever. So we can write goals based on that. So, see this poor executive functioning, limited self-awareness, especially awareness into their disability. They still feel like they're able to do more they lack that awareness of their limitations a lot of times. Depression is very common with people with brain injuries, including strokes, traumatic brain injuries, of course. Axis 2 and Axis 1. You psych majors are familiar with this, right? But those of you who are not psych majors, I thought maybe we won't be as, oops, I lost it. So I put a little link in here. Verywellmind.com is kind of a nifty website, I like it. Oh man. So there's some cool reading in here, and for those of you who aren't as haven't been as exposed to the psych stuff, there's these 5 axes in terms of, we talk about mental health and diagnoses, and Axis 1 really has to do with the mental health, substance abuse, psychiatric disorders, and then Axis 2 you'll see personality disorders, and this website still uses the term mental retardation. And that's like scandalous today, but just as a little history lesson, we used mental retardation for years as a diagnosis. Where are my, oh man, I like this. Where are my musicians at? We got 1, 2? So when you are playing the oboe,
What's that?
or the piano, or the saxophone, or whatever you're playing, and you come across this in the music, you're just playing along your oboe, and you see the RIT period, what do?
Slow down.
You know to slow down. Why?
Because that's what that word means.
It is an abbreviation for what word? Very nice. I was gonna say it wrong. Retardando, which is Latin for slow. So retarded or retardation has always been a clinical term, a diagnosis we use to talk about how somebody is mentally slow, or we might say that their development has been retarded because of such and such or whatever. So we use the word retarded not in a pejorative sense or in a insulting sense. We use it just to describe the slowing of something, mental skills or whatever. So when you see that, don't be scandalized. We used it here. Now we use the term intellectual disabilities. Here they say intellectual development disorder, which I'm not really familiar with. We say intellectual disabilities around here. So anyway, so when I had it in that slide, people who have suffered a traumatic brain injury will have Axis 1. They might have some mental psychosocial issues. They might have personality disorders or intellectual disabilities subsequent to the brain injury. So, you guys need a break?
Yes.
I thought you might. All right, take.
My brain is hurting from talking about the brain. Did I get it?
It's making your brain hurt. Take a break. Be back in 10 minutes. 3 after.
Talking about